It's a pleasure to welcome you to today's Mini-Symposia session 1.4, titled In the Fight, Advancement and Challenges in Cervical, Breast and Prostate Cancer Prevention, Screening and Treatment. We are honored to have this session moderated by Professor Mahika Senavikrama, a seasoned expert in the field. Professor Senavikrama is a board-certified public health specialist and an esteemed academic researcher with over 23 years of experience in curative, preventive healthcare teaching and research. She serves as the head of the Department of Community Medicine at the Faculty of Medical Science and is also the director of the Center for Cancer Research at the University of Sri Jayawardenepura, Sri Lanka.
These cancers represent some of the most common malignancies worldwide, causing significant morbidity and mortality. In low and lower middle income countries, including regions of Asia and countries like Sri Lanka, the burden of these cancers is particularly acute, exacerbated by limited access to screening, early detection, and comprehensive treatment options. Prostate cancer, the second most common cancer in men, poses unique challenges related to its diagnosis, particularly in regions with inadequate access to screening tools such as prostate-specific antigen testing. Globally, breast cancer remains the most common cancer in women, accounting for 2.3 million new cases in 2022, which is largely preventable through vaccination and regular screening, still claims over 340,000 lives annually, with 90% of cases occurring in low and lower middle income countries. Today's session aims to explore the epidemiology of cervical, breast, and prostate cancers, outline public health strategies to reduce the impact of these cancers, evaluate the effectiveness and accessibility of screening programs, and to identify disparities in prevention and treatment access for these cancers across different populations. We have three distinguished panelists with us here today. Professor Isha Premathilaka, Dr. Kanchana Vijayasinghe, and Dr. Diana Constanza Pellido will share their experiences and insights during this symposium. Professor Isha Premathilaka, who is seated right me, is a specialist in histopathology with over 30 years of teaching experience and more than 20 years as a board-certified consultant in public and private sectors. A professor in pathology at the Faculty of Medical Sciences, University of Sri Jayawardenepura, an honorary consultant histopathologist at Colombo South Teaching Hospital. She specializes in gastrointestinal and urological pathology. Dr. Kanchana Vijayasinghe is a board-certified general surgeon with a specialization in breast surgery and over 15 years of clinical experience across public and private health care. She serves as a senior lecturer in the Department of Surgery, Faculty of Medical Sciences, University of Sri Jayawardenepura, and practices as a visiting surgeon at Colombo South Teaching Hospital. Dr. Vijayasinghe is the secretary of the Sri Lanka Society of Breast Surgeons and has published research on breast diseases. And Dr. Diana Constanza Pellido holds a master's in public health and a master's in HIV/AIDS, with over 14 years of experience across clinical practice, policy research, and program evaluation globally. She has led health and nutrition integration in humanitarian settings, focusing on sexual and reproductive health, gender-based violence, maternal and child health, nutrition, and mental health. Formerly acting director of programs at Save the Children Colombia, she now serves as Global Humanitarian Technical Lead for the International Planned Parenthood Federation.
This is a cancer which occurs mostly in older men over 50, with a much higher incidence over 65. It's the same in other parts of the world as in Sri Lanka. And it's not a cancer that is involved with a lot of risk factors which you can prevent, but there are some known ones like family history. If a man has a father or brother or close relative who was diagnosed with prostate cancer at less than 55, or if they have family members with cancers associated with BRCA gene mutations like breast, ovarian or pancreatic cancer. It's known to occur more in African Americans, and it's less in our part of the world. And there are some dietary factors vaguely associated, like increased red meat, processed meats, and less fruits and vegetables, obesity and lack of physical activity, and also chemicals like those found in cigarette smoke, vehicle exhaust fumes, DDT, and cadmium. So the early symptoms, this is a cancer that doesn't give early symptoms, right? So like the symptoms they do get somewhere in their disease are due to, obstruction of urine flow. And mind you, obstruction of urine flow is not just due to prostate cancer, it can be due to benign prostatic diseases. But it's important to make men aware that it could be a cause. So frequent urination, difficulty in starting urination or holding it back, weak or interrupted flow. Also less common, they can have burning sensations or discomfort in the pelvic area or blood in the urine or in the semen. Treatment depends on risk stratification. There are several methods of stratifying risk. Most of them use the Gleason grade and the PSA and the stage of the disease. So this is a tumor, interestingly, which if it is slow growing, men can live with and die of other causes, right? So those are called low risk tumors, and they are offered what we call active surveillance, where they have routine checks for PSA or digital rectal examinations or biopsies at regular time intervals. This is a bit of a problem in our setup because in the state sector, people might just trot off and never come back again. Right? So still for all that is the option for low risk cancers. And higher risk cancers, in our country it's mostly radiotherapy because there are too many surgical complications from radical prostatectomy. But in the West, where they have perfected this more, there are a lot of radical prostatectomy still happening. And if it has spread, you can give other treatment options. Right. Now I come to my first key point. Prostate cancer in Sri Lanka is probably still underreported. Professor Chandu D. Silva back in the 90s published a paper on this, that it's underreported, and things have improved since then. But even in the 2021 statistics, it's the 5th commonest cancer in Sri Lanka, whereas in 21 in Western countries it was the 2nd commonest. Now in USA and in UK, it's the top cancer in men, right? So I still feel that we're missing something. Right? It's only 7.5% of the cancers in our men. This is the latest data available. Right? Now, PSA testing is a double-edged sword. There are good things about PSA and bad things. The good things are that it's known to reduce mortality in high-risk populations. It's just a blood test. And there are newer modifications like PSA density and velocity, which are supposed to increase accuracy. That being said, it's known to have false negatives, false positives, interracial differences, interlab differences due to the testing technique they use. And okay, this, as I said, it can be a slow growing indolent cancer. But if the man knows he has a cancer, then he's going to be anxious and go ask for various other investigations which may not be necessary, right? PSAs are expensive. In this country, in the private sector, it's like 10 to 11,000 bucks, right? And also, the cutoff point, it has always been traditionally 4 nanograms per ml, but there is debate about this cutoff point. It may depend on the age, etc. That's my next point. Most of our cancers, prostate cancers, are high grade, unlike the West. Okay? Now, what's grade? It's defined by this thing called a Gleason score, right? And what we do is we look under the microscope for these patterns that we see, right? And then we, it's a combination that we give of 2 patterns, usually the predominant pattern and the worst pattern. Now, of these 5 patterns that Gleason originally divided it to, Nowadays, we don't even call the first two cancer, right? So then we have basically two patterns we are dealing with. Three patterns, right? Now, grade groups are a newer modification by the WHO, where they took all the possible combinations of the Gleason scores and divided them into 5 grade groups, okay? This is simpler to do, okay? And it provides better risk stratification. You'll notice that the 7s have been split, okay? With the ones that have predominantly pattern 3 cancers and ones that have predominantly 4, because they behave differently. So it's more accurate in risk stratification. Also, imagine telling a guy you have Gleason score 6 cancer out of 10. He thinks, oh God, I'm dead, right? But it's actually the grade group 1, which is the most indolent cancer. So grade groups reduce over-treatment because they can better distinguish aggressive and non-aggressive cancers. But nowadays, we are still evolving, so we give both in our reports. Some urologists use Gleason score still for risk stratification, right? This is the future. Molecular tests, artificial intelligence for grading. Even now, there are modules online which do AI grading of prostate cancer, but this is still not in clinical use, right? This is an ongoing study, and at the moment we have about 345 cases from 4 centers, and our mean age is on par with other studies in Sri Lanka, older studies. And this was a question I had when I came back from UK, because in UK you have very small quantities of very low grade cancer, and here it's teeming with high grade cancer. So I wanted to see whether this is actually true. And so far, it seems true, because 20% only are Gleason score 6, and the rest, 80%, are 7 or higher. Grade groups, you can see it's equally spread across the grade group. Comparing it with a study from UK is different, okay? This is Dan Burney's study, and his one is in blue, and you can see that they have far less of the grade group 4 and 5 cancers, and we compared with our grade groups, which are going across all the grades. My next point is that most people don't die of their prostate cancer. This is 2021 from Sri Lankan Cancer Control, NHS UK and CDC USA, and you can see the death rates are pretty low, especially in UK, right? So, but in our country, this is NCCP data, and the prostate cancer death rate is slowly creeping up. Whereas in the US and UK, it is definitely going down. So now we have a lot of high-risk cancers, high-grade cancers, right? Even Balagovi et al. Did a study in Jaffna, found 80% of their cancers are high risk and less deaths. Why? There are probably several reasons for this. One is grade migration. As I said, Gleason grading has evolved. So some of the things that were lower patterns are now higher patterns. So then the overall grade grows up, right? But that's a small factor, because even the older studies had less low-grade cancers in our country, right? But the more important factors are, this is a slow-growing cancer, so most of them probably don't die of it. We don't know how many cancers we actually have, right? And there is a severe dearth of follow-up data, so we don't know whether they died of them or not. In 2020, I was happy to be a part of this, and it states that PSA-based screening should be done if the man is over 50, or if you want to do it in a younger person, they should have strong risk factors. If the PSA is high, refer to a specialist for further evaluation. Avoid over-screening, that's stressed, okay? Balance the benefits with the potential harms. And when it's confirmed, refer to oncology immediately. Now, that's my last key point. It's really difficult to do prostate cancer research here, because in the government sector especially, there are very few clinical databases being maintained. We can't even get the PSA values of patients, right? And even the data we have is not uniform. People are re-stratifying in various ways, testing PSA in various methods, etc. And there is no integration with our pathology data or the radiology data. So, basically, the public and primary care physicians should be educated that although prostate cancer is mostly indolent, there can be aggressive tumors, and the purpose of screening is to catch those aggressive tumors and not to treat the ones that are indolent. Overscreening is not advised. We have perfectly good guidelines which should be followed, and although it's not strongly linked to a lot of risk factors, things like smoking, which are preventable, should be avoided. And for tertiary care centers, it's time we established good databases. And I think the colleges have a role to play in establishing a dialogue for this. And those databases should be comparable. So there should be standardized PSA testing methods, radiology reporting, biopsy protocols, pathology reporting, risk assessment, and treatment protocols. Thank you.
Will do. So I think we're going to move on from prostate cancer to breast cancer. And I would like to start off by saying Prof. Isha said that although prostate cancer is it's not very common, but the real cancer-related deaths are uncommon with prostate cancer. This is completely the opposite when it comes to breast cancer. Today in Sri Lanka, the highest cancer-related mortality among women is due to breast cancer. So let's see what we can do about this. Right. So I'm sure you all know that breast cancer is the commonest cancer among women globally. This is the same in Sri Lanka. The incidence, as you can see, is on the rise. Couple of years ago, I said in similar speeches that we had about 3,000 new patients diagnosed every year. Now it's close to 6,000 cases per year, so it's on the rise. Nextly, you can see when you look at the cancers among females in Sri Lanka, breast cancer is at the very top, and it is very unlikely the other cancers are going to beat it, because if you look at the incidence of its rising, breast cancer has a very steep rise. When we look at the WHO projection, you can see in the South Asian region, they are projecting that there will be a 50% rise in new breast cancer cases over the next 2 decades. And look at the next one. It shows that the breast cancer-related deaths will also rise. So there's a dying need to do something about this. So to address this issue, I generally put this slide to show how we can beat breast cancer, and there is a silver lining in the cloud. So just like any other cancer, like prostate cancer or any other cancer, it starts from one cell, and it will start spreading locally, and it will go out into the body. So you can see we have a stage 0 in breast cancer to 4, and at the bottom you can see the survival rate. That is how well we can cure a patient once they present at a particular stage. Now what I want you to see is, if you look at stage 0 and 1, we can almost guarantee 100% cure rate, whereas it keeps dwindling when it goes to stage 2, 3, and 4. Now where do you think our Sri Lankan women are commonly? We would love to see them in stage 0 and 1, but we hardly see them. They are commonly in stage 2, 3, and 4. So as I said, so the first pillar was early detection, and we have 3 simple techniques for that. Self-breast examination, which is something the public can do. You don't need doctors for this, and I'm sure you all well versed about this. With self-breast examination, we can identify patients. We try to target to identify them at stage 1, because most of the time our women present with the incidental finding of a lump. When they are taking a wash, when they are taking a shower, they feel a lump, and that is a random, they feel a lump randomly. For that random lump to be felt, it has to be quite big, and they are always in stage 2 and 3. But if you know about your breasts, then you will be able to identify at stage 1. Same principle for clinical breast examination, getting a doctor's checkup annually, especially for women above 40. That will help us to identify at stage 1. But if you look at this picture, you see at stage 0, there is no lump. So there is no way a doctor or a woman can identify the cancer. And that is why we have screening mammography. A mammogram can detect a cancer, a breast cancer, even before it turns into a cancer, at a very, very early stage. So that is why in the developed countries, they offer this free of charge for women roughly above 45 years of age. Now, unfortunately, in Sri Lanka, I don't see this happening for the next 20 years or so. We will not be able to offer free mammograms, because we have a waiting list for even breast cancer patients to get a mammogram done. But at Sri Lankan level, I still think we can go ahead with self-breast examination and clinical breast examination and try to target to see most of our patients in stage 1. So now, as Prof. Isha said, we do in Sri Lanka have lots of campaigns. We have the National Cancer Control, we have other NGOs, charity organizations doing so many campaigns. And I don't think, I'll hardly find a female who's not aware that breast cancer is the commonest. And they are aware about these techniques of examination also. If you look at this was a research that we conducted a couple of years ago on females diagnosed with breast cancer. Majority of them were aware about the technique. But for some reason, if you look at the numbers that were practicing, we are just parroting out theory, and we are not highlighting why we need to identify early, and that is to improve the survival. And also this study went on to find out, right, so the women, we inquired from these patients with breast cancer how long they stayed at home before presenting. And you can see about 50% of the patients stayed at least 3 months before seeking medical advice. So we need to address this also, because when you wait for 3 months, obviously you understand now that the patients will present quite late, as seen in these pictures. So I think we as Sri Lankans have to look at the way we are setting up on breast cancer awareness campaigns. We need to see that they are practicing. No point preaching with lectures. So we went on to find out why these females are presenting late. What's the problem? And majority of them had fear of being diagnosed with breast cancer, fear of treatment. If you actually really listen to them, they are very worried about losing their breast. Because the current concept is they think breast cancer, I'm going to lose the breast. But that is not so. Now we can offer breast conserving surgery. So these kind of myths have to be dispelled. Other thing is, so if you look at Sri Lanka, so to diagnose breast cancer, we generally need a mammogram. We generally have about 15 to 20 mammograms to the entire country. Colombo in the public health sector. So in the government level, in Western Province, we have about 3 to 4 mammogram facilities, but when we go to the peripheral provincial provinces, we have about 1 mammogram per province. To give you an example, practical example, a female patient came to Colombo South Teaching Hospital due to a connection with another healthcare worker. She was from a different province. She was given a 2 months waiting list for a mammogram. Clinical diagnosis was breast cancer. So she was diagnosed in August, was waiting for a mammogram in October. So she landed in Colombo South Teaching Hospital, got it within a week's time, and she was operated before October. Same with, as I said, same with treatment. Closer you come to the Western Province or the provinces with better facilities, we give better surgical facilities, sooner surgeries, the treatments are done sooner. Further you are away, they have significant problems in transportation, financial issues. So these things make them delay their process of being treated soon, and the patients also feel reluctant to go and seek medication because of these problems and waiting lists. So 3 aspects that the WHO has mentioned to us, 3 pillars: early detection, timely diagnosis, and timely management. And I think Sri Lanka is still on the way to reach the optimum level, and we need to address these issues. Medical and non-medical all should get together and try to sort out this problem, because we, as I said before, breast cancer is the leading cancer among women, and we have a dying need to address these issues for our own women. Thank you very much.
You can see here that cervical cancer is the 4th commonest cancer in women globally, with about 600,000 new cases by 2022 and 350 cases of deaths by 2022 as well. 9 in 10 cervical cancer deaths worldwide occur in low and middle income countries. As you can see in the heat maps, both of the trends are in the south, right, in the global south. 90% of those trends in 2020 were located or concentrated in low and middle income countries. What about the estimations or the projections of the new cases and also the death by 2050? You can go through the Global Cancer Observatory from the International Agency of research on cancer. It belongs to the IARC international agency, and it is closely in collaboration with the World Health Organization, so you can go through it and just play and navigate throughout the dashboard. It will give you wonderful information and projections about different types of cancer, including cervical cancer, breast, prostate, lung, etc. So by 2050, we will have around, or more or less, 1 million of new cases if we do not do anything to tackle the situation. Also, we expect that 400,000 deaths will be in place by that time if we don't do anything to intervene from the public health perspective. So also you can find this type of graphics and pictures and these figures from the the Global Observatory of Cancer from IARC. So you can do some comparisons between the trends in regards. You have in the x-axis the categories from the World Bank in relation with some of the countries are in high income or low income, and you can see the trend of the new cases or the incidence per thousand of people, of women at risk. Unfortunately, the number here, the percentage didn't appear, but by 2050, high income countries only will increase their new cases in 7%. In comparison with the low income countries, plus 152, if we do not do anything around it. So by 2020, the World Health Organization launched the Cervical Cancer Elimination Initiative, and it is driven by this global strategy to accelerate the elimination of cervical cancer as a public health problem. It has 3 targets, special targets that should be accomplished or achieved by 2030. So 90% of the girls should be fully vaccinated by that time, 2030.